Okay, so this is going to be the second part of the respiratory tract infections, and we're going to focus more on lower respiratory tract infections today. And the first set will focus on bacterial infections of the lower respiratory tract. And so the first disease that I want to talking about is pertussis, or which is also called whooping cough. The cause of the disease is a gram-negative bacillus called Bordetella pertussis. Now, this bacteria is usually transmitted through droplet transmission from infected individuals. And upon inhalation of these droplets, or it could be direct contact or even indirect contact, really, but upon being infected with the bacteria infects the cells of the lower respiratory tract, especially the pseudostratified ciliated epithelium of the trachea. And once there, the bacteria secretes two very powerful toxins. One's called the pertussis toxin. Now, this particular toxin causes the cells there to secrete a lot of mucus. If you remember, there's a lot of goblet cells there whose normal function is to secrete mucus. Well, the pertussis toxin induces even more mucus production. And we also have the tracheal cytotoxin. Now, the tracheal cytotoxin actually first paralyzes the cilia there, and then eventually kills the cells that have the cilia. So what ends up happening is that with the paralyzation of the cilia, the mucus cannot be moved up and out. Okay, it's not thinned out. And so the mucus layer becomes thicker and thicker and thicker, and it becomes very hard to breathe. And people that suffer from severe forms of the disease, they suffer from these very violent, convulsive types of coughs. Now, there's 4 stages to pertussis. Okay, the first stage is a fairly long incubation period, about 1 to 3 weeks. And then a person will start to enter into the next stage, which is called the cotural stage. The cotural stage is this very long prodromal phase. Remember that a prodromal phase is where a person is really exhibiting some very mild symptoms. And that's what's going to happen here. Some of the symptoms might resemble like a mild form of the cold or the flu, where they experience some coughing, sneezing, and runny nose. But then as the mucus builds up and as the ciliated cells start to be paralyzed and they die, this causes a lot more mucus, that very, very thick layer of mucus that can't be moved out, and people will suffer from these very violent, very wheezing type of coughs. So violent that a person can even go into convulsions because of it. With treatment and proper care, a person can enter into convalescence, but it is a fairly long process. So again, droplet transmission, symptoms, runny nose, violent coughing, eventually as the ciliated cells are paralyzed and killed. And of course, the best way to protect against this is to immunize. Okay, and this is again with the DTP vaccine, and it's the P portion, okay, that protects against this. So this is again another toxoid. All right, now tuberculosis is caused by Mycobacterium tuberculosis. Now, just a couple of things to remember. Any bacteria that has this genus name, okay, Mycobacterium, these are acid-fast bacteria, which means that they have these mycolic acids in their cell walls. And so mycolic acids are lipids. And the fact that they have these very thick lipids, these mycolic acids in their cell walls, makes them very resistant to drying out, makes them very resistant to disinfectants, also makes them very resistant to the penetration from antibiotics. This particular bacteria is a very slow-growing bacteria. For a population to double, it can take anywhere from 12 to 24 hours, depending on the strain. Now, there's 2 types of tuberculosis. There's primary TB, and then there's secondary TB. In primary tuberculosis, upon inhalation of the bacteria travel all the way down to the air sacs in the lungs called the alveoli. All right, and so this is where the oxygen in the alveoli diffuses from the alveoli into the capillaries underneath, and then carbon dioxide is diffused the other way. So this is where a lot of gas exchange happens. Well, here, what's going to happen primarily is that the bacteria, they get into the alveoli, and they're immediately phagocytosed by these alveolar macrophages. But the problem here is that the macrophages cannot destroy the bacteria. Okay, so the bacteria actually live inside of the macrophages, and they'll live in there and they'll reproduce. They'll make numerous new bacteria, and eventually they'll kill the bacteria. They'll kill the macrophage by popping the macrophage and by lysis, and that releases numerous new bacteria. So what then happens is that your immune system, assuming that you have a healthy immune system, will send in more macrophages. And so this cycle repeats. So every time a macrophage bursts open, releases new bacteria, more macrophages are sent in. And so what we have here is the beginnings of a tubercle, okay, which is really just a big ball of macrophages. So this is really what you kind of want to happen in the initial stages of the disease. What your body's trying to do is trying to really seal off and wall off this infection. So as again more and more and more macrophages move in, okay, we have a tubercle. Okay, and so not only is the body trying to seal off this infection to prevent it from spreading to other parts of the lungs and also the capillaries underneath, but also the immune system is trying to kill any of the cells, the bacterial cells remaining. So in the very least, either they will all die, or the bacteria will remain dormant. The other thing in primary tuberculosis that'll happen is that your body, again, to really seal this infection off, will start laying down layers of collagen fibers around this. Okay, so again, we're trying to prevent the infection from spreading. Okay, now in primary tuberculosis, the patient is not contagious because the infection is limited to this area, and they often don't have any symptoms. And perhaps the only way that they would ever know that they're infected is if they get a chest x-ray where they will show presence of the tubercles here. All right, now, so what I just described, primary tuberculosis, this was what would happen if the person has a healthy immune system. But let's say something happens and the person has a weaker immune system. Well, then what can happen is that a person can enter into the next stage called secondary reactivated tuberculosis. So in this stage, the tubercles can rupture because of the weakened immune system, and the bacteria within can leak out and spread to other parts of the lungs and into the capillaries underneath. So in this stage, the person is highly infectious. When the bacteria spreads into the blood capillaries underneath, the blood can carry it to multiple organs like the bone marrow, the spleen, the kidneys, the spinal cord, even the brain. And they can even develop tubercles in those organs and cause destruction of those organs and the tissues within. This type of tuberculosis is called disseminated tuberculosis, disseminated, or sometimes called miliary. This means spread. So here's what's happening. So in secondary reactivated TB, again, usually as a result of a weakened immune system, the bacteria, the tubercles are rupturing, bacteria leaking out into other parts of the respiratory tract and also into the blood capillaries underneath, and that can cause it to spread to other organs. So again, primary TB, often no symptoms, not contagious, and even if the bacteria aren't killed inside the tubercles, they can remain dormant for years and years and years. Okay. A lot of times those tubercles over the course of the years will actually start to develop, will actually deposit calcium within, and these tubercles with calcium deposit in are called Gons complexes. This is a histological view of a tubercle, and so again, it's just really a lot of just aggregated macrophages, and you can see here right around that an accumulation of a lot of collagen fibers around this. Secondary reactivated TB, usually a result of a weakened immune system. The tubercles rupture, spread to other parts of the body, and not only the lungs, they spread to other parts of the body, multiple organs get infected, and of course the patient is highly infectious. Okay, so the incubation period for this, which is something you should know, is about 3 months or longer, because the bacteria grows for so long. And treatments for this are a combination of drugs: isaniazid, rifampin, and ethambutol. Okay, those 3 drugs are part of what are called the first line of defense drugs against tuberculosis. Possibly another drug, streptomycin, would be given, but definitely isaniazid, rifampin, and ethambutol. Now, isaniazid, its mode of action, isaniazid and ethambutol, by the way, their mode of action is to attack the mycolic acids, and that allows rifampin to penetrate the cell and attack transcription. Okay, so it's a fairly long treatment. So like I said, in primary tuberculosis, there's often no symptoms, but in secondary tuberculosis, person will suffer from night sweats, fever, as the tissues are being wasted away, a lot of weight loss, and a cough, and a very productive infectious cough. Okay, just a couple of really quick things. There is a vaccine against tuberculosis. In a lot of high prevalent areas, the vaccine is given. But in the United States, it is not given because when a person is given the vaccine, which is based off of the antigens from the bacteria, if they ever get tested for tuberculosis, they will show up positive. So, in the United States, tuberculosis, the prevalence rate and the incidence rate is very, very low. So if we vaccinated everybody in the United States against tuberculosis, everybody would show up positive, and we would lose our ability to distinguish who's really positive and who's really infected, who's not. Okay. The test, there's actually two tests. One's called the Mantoux test. One's called the Tyne test. They're pretty similar, although the Mantoux test seems to be the more common, more accurate one. What's involved is that they actually inject a little bit of the antigen underneath the skin. And the test is actually based off of a type 4 delayed hypersensitivity reaction where you have to come back 48 hours later. And if you're positive, you would have an induration. It's kind of like a blister that would happen. And of course, the induration would have to be of a certain size in diameter to actually prove that you're positive. If there's no reaction, or if the diameter of the induration is less than a certain amount, then it usually means that you're negative. Okay, anthrax. Now there's actually 3 forms of anthrax. You have an inhalation form, a skin form, and also a gastrointestinal form. So for right now, really quickly, we're just going to focus on the inhalation anthrax. All 3 forms are caused by exposure to endospores from Bacillus anthracis. Now for the inhalation anthrax, what has to happen is that a person has to inhale the endospores. And people that are more at risk for this are people, for example, that work with animals. So cattle, sheep. In fact, this disease used to be called wool sorter's disease because people that would work with sheep and actually, shear the wool off of the sheep would be exposed to the endospores as they inhaled a lot of the aerosolized fur and things as they sheared the wool off the sheep, because the endospores tend to attach to the skin and the fur of a lot of animals. And so people that work with animals, they're more at risk of contracting this disease than anybody else. And that's primarily the way that a person gets infected. There is no person-to-person transmission. The toxin that's made by the bacteria kills a lot of the cells in the lungs and causes a lot of very severe edema and shock and even death. And in fact, even with aggressive treatment, most people die from this disease. Some of the initial symptoms might resemble the cold or the flu, and later that develops into more severe coughing, nausea, vomiting, and even shock and death. There is a vaccine against this, but we don't distribute it widely. It's mainly given to people in the military who might be at risk for exposure through biochemical weapons or people that work with animals. All right. Pneumococcal pneumonia. So this is what's often referred to as either lobar pneumonia or adult pneumonia. And the number one cause of this is Streptococcus pneumoniae. There's many different strains or serotypes of the bacteria. And there's actually a vaccine against it that can protect against it. I'll talk about that here in a minute. The bacteria is usually transmitted through droplets, and once the bacteria gets inhaled into the lungs, it starts to replicate, kill some of the cells there, establishes a very an inflammatory reaction there where you move in a lot of white blood cells in there. And as a result of the inflammation, fluid builds up in the alveoli, and it makes it very difficult for oxygen and carbon dioxide to be exchanged between the alveoli and the capillary bed underneath. One of the reasons they call this lobar pneumonia is because it doesn't affect the entire lung. It only affects one lobe of the lung. So some initial symptoms: cough, fever, and chills. As the fluid starts to build up inside the lungs, shortness of breath. And even if there's a little hemorrhaging, there could be some rust-colored sputum. Treatment for this, it kind of varies. I'm not going to dwell on this a whole lot. maybe penicillin if the bacteria is not resistant, but if it is, a third-generation cephalosporin or erythromycin. In very severe cases, chloramphenicol can be given, but the thing you have to worry about chloramphenicol is a person could suffer from aplastic anemia because of this. As I mentioned before, there is a vaccine against it, but it's typically given to the elderly, so people that are more at risk for developing or contracting pneumonia, or people that work with patients that have pneumonia, or even people that work in a lab where they do a lot of research on it. All right, so some other types of pneumonia, Klebsiella with hemorrhagic pneumonia, and also Mycoplasma walking pneumonia. So Klebsiella pneumoniae, it's the cause of what's often referred to as hemorrhagic pneumonia. Now, Klebsiella pneumonia is actually a gram-negative enteric bacteria, but if inhaled, it can cause a very severe type of pneumonia. Not only does it cause a lot of just fluid buildup and just killing the cells, it causes permanent damage, so much so that it can actually cause a lot of hemorrhaging and bleeding inside the lungs. And people that have a very severe form of this, they can have bloody sputum when they cough. Usually transmitted through droplet transmission, and usually treated with antibiotics like third-generation cephalosporins. Now, mycoplasmal or walking pneumonia. It's caused by Mycoplasma pneumoniae. Something to remember about the genus Mycoplasma is that the bacteria within this genus do not have a cell wall. So you can't treat it with penicillin because they don't have a cell wall. The reason this is called walking pneumonia is because after infection, when a person starts showing signs and symptoms, it usually starts off with kind of a gradual sort of cough, and it's really more of a dry hack. It's not really productive. And so people walk around with the disease, not exactly knowing what they have. That usually then progresses into a kind of a low-grade fever, feeling malaise and fatigue. The number one treatment for walking pneumonia is erythromycin. And the age groups that are more commonly infected than others are children, okay, usually from school, from other kids. Now, chlamydial pneumonia, or the bacteria that causes this, is Chlamydophila pneumoniae. This has really nothing to do with the STD. But a lot of the symptoms of this resemble walking pneumonia caused by Mycoplasma pneumoniae, and in fact, the treatment is the same with erythromycin. Legionnaire's disease. Now, the very first time that Legionnaire's disease was discovered was in 1976 at a Legion's conference, where a lot of people at a hotel attending this conference became sick with this very strange pneumonia. And when they isolated samples from these individuals, they identified this bacteria that they named after the Legion's conference. They called it Legionella pneumophila. This is really the very first time that they actually discovered it. And so the only way that this bacteria is transmitted is through the bacteria being sprayed out in fine mist of water, say from air conditioners, spas, humidifiers, fountains, that kind of thing. Some of the initial symptoms are high fever, cough, malaise, and then development of pneumonia. Treatment for this is erythromycin. So as I said, it's the very first time it was discovered in 1976. It's a very fastidious bacteria, which means that it's very picky in terms of how it grows. So growing it in the lab is pretty tough. Okay, so now we're going to be focusing on some viral infections of the lower respiratory tract. And the very first one that I want to talk about is the flu. Now, the influenza virus, it's an RNA virus. It has an envelope, and stuck in that envelope there are two spike proteins. One's called the hemagglutinin spike, and the hemagglutinin spike is usually used by the virus to attach to host cells. Okay, and then there's another spike in here. It's called the neuraminidase spike. This is typically used as an enzyme to release the new virions from the host cell. So as those new virions, as they're being produced, they start to emerge from the virus. And in order to kind of detach itself from the host cell, it uses this neuraminidase enzyme to cut away this little protein that ties it to the host cell, and then it's released. All right. So it's usually spread through droplet transmission, and the bacteria is inhaled, and it infects a lot of the epithelial cells of the lungs and even kills them. A lot of inflammatory reaction happens, increase in mucus production, coughing, sneezing. But also, what's really unique about the flu is that when a person gets the flu, they have a very sudden onset of symptoms, mainly a sudden onset of fever, very sudden onset of fatigue. So much so that a person can be fine 1 minute, and then the next minute they have a lot of these symptoms. Of course, there is a vaccine against the influenza virus, but the vaccine only covers strains that are causing most of the cases of the flu during that season or during that year. But if you are infected with a strain that's not covered by the vaccine, you could still get the flu. Medications that are given for influenza are either amantadine or Tamiflu, but these are typically given in very severe cases. Now, the influenza virus can mutate in one of two ways. One's called antigenic drift, and the other one's called antigenic shift. Okay, the most common way that it mutates and creates different strains is antigenic drift. So this causes a very slight change in the virus. Now, the way that this happens is where a particular strain of the virus that we'll start off calling influenza virus number 1 infects a host cell. And while it's inside the host cell, it undergoes a very slight change. Okay, so the genes mutate very slightly and produce very slightly different spike proteins on the surface. And so what's released from the host cell is not really a completely different version of the virus, but it's more of a very slightly different version. Okay, you can see here that they started off with an influenza virus 1, but now this slightly different version, they're calling this influenza virus 1 prime. So it's the same virus, but a slightly different version. And so most of the strains that emerge are caused by, are produced by this method of mutation. And you can see here that we have outbreaks of influenza caused by antigenic drift mutations about every 2 years or so. Now, the more severe change is antigenic shift. Okay, and we have outbreaks caused by this about every 10 years or so. Now, this is very severe because what's really going to happen is that we're really producing a brand new strain of the virus that nobody has interacted with before, and pretty much nobody has immunity against, and that's why it causes really severe symptoms. The way this works is that you have to be infected by 2 different strains of the virus at the same time. Okay, and inside the host cell, these 2 viruses, their genetics. Their pieces of RNA undergo a lot of genetic recombination. And what emerges is a brand new strain of the virus. Okay? Again, something that nobody has interacted with before and nobody has immunity against. And it can spread very quickly through the population, and the symptoms, because nobody has an immunity against, are very, very severe, even can cause death. And outbreaks from this occur about every 10 years or so. An example of antigenic shift happening is the bird flu. In bird flu, what has to happen is that a person is infected with the human version of the flu, but at the same time, possibly through contact with birds like chickens or ducks and things like that, they get infected with the bird flu version. And so at the same time, those 2 viruses, they exchange genetic information, they undergo a lot of recombination to produce a brand new strain of the virus. Again, something that nobody has an immunity against and causes very severe symptoms. If you look at the bird flu, which we typically see in more Southeast Asian countries, because nobody has an immunity against it, the fatality rate is about 50%. Okay. Respiratory syncytial virus, or RSV infections, usually transmitted through droplet transmission or droplet transmission. Upon inhalation, a person can suffer from coughing, wheezing, runny nose, and eventually difficulty breathing. Although anybody can get infections from this virus, it tends to cause more severe infections in infants because of the lack of their immune system. They contract this disease called bronchiolitis, where a lot of the cells in the bronchioles, they die, develop a very thick layer of mucus, which makes it very, very difficult to breathe. And the really only treatment for this is supportive care. There is no vaccine, there's no antiviral medications. There is a possibility of antibodies against the virus being given, but other than that, there really is no vaccine. We typically see more RSV infections in the winter months, especially in the South. Okay. Another viral infection of the lower respiratory tract, hantaviral pulmonary syndrome, caused by the hantavirus. Okay, usually now although we don't see any cases of this in the southeast and some of these other states here, if you look here in some of the western states, Midwest and Western, we do see a lot of cases. Well, more cases of it. And the way this is transmitted is through inhalation of infected dry mouse urine, feces, or saliva. Okay, so it's a type of deer mouse that can carry this disease. And although the mouse itself may not be affected, the mouse can release the virus in their urine and feces and saliva. And so if a human inhales dried up saliva or urine or feces, they can get infected. And it's a very severe type of pneumonia. The person will also suffer from very high fever, cough, a lot of muscle aches, and if they don't receive a lot of supportive care, they can go into shock and possibly die from it. There really is no treatment for it other than controlling the rodent population that can carry the virus. Okay, so now we're going to go into some lower respiratory tract infections caused by fungi. All right, so the first one I want to talk about is coccidiomycosis, or also known as valley fever. This is caused by a fungus called Coccidioides immitis. And we see outbreaks of this more often in the West and in the Western states, okay? Because the spores from the fungus tend to like to live in very dry, arid environments. And so a lot of these states here, there's a lot of desert areas where the spores tend to hang out. And just if the spores and the dust there get aerosolized, people living there can inhale the spores and get infected. Now, most people that get infected either will have no symptoms or at the most maybe have some flu-like symptoms. This tends to be more of a problem with people that are immunocompromised, like AIDS patients. As far as treatments for this, this antifungal drug, amphotericin B, is the #1 treatment for it. Histoplasmosis. Okay, this is caused by this fungus, Histoplasma capsulatum. The spores from this particular fungus love to live in nitrogen-rich soil. So that would be like chicken droppings that we would typically find in chicken houses, bat guano that are found in caves or wherever bats are. And so people that are working at chicken houses, they can inhale the spores from the droppings there. People that have gone exploring in caves where there's bats that have been infected, the bat guano can actually have a lot of the spores there, and they get infected. And histoplasmosis is the most common systemic fungal infection. However, if you look at the rates of infection and symptoms, most people that are infected will have mild or no symptoms. It really only causes very severe infections in 5% of those that are infected. So 95% or more of people that are infected will have no symptoms or very mild symptoms. And some of those mild symptoms would probably resemble the common cold or the cough. So the treatment for this would be amphotericin B, which again is a very popular antifungal drug to treat systemic fungal infections. Okay, and really the last disease that I want to talk about is pneumocystis pneumoniae, which is caused by this fungus, Pneumocystis jirovecii. This is an opportunistic infection in the immunocompromised, especially AIDS patient. Back in the early days of the AIDS epidemic, if a person came to their doctor's office infected with this, it almost always meant that they had AIDS, because the only people that contracted this disease were AIDS patients. People that have a healthy immune system are not typically infected. And so in these individuals, it can cause a very, very severe type of pneumonia. And you can see here that before 1980, there were maybe 100 cases per year. But as of 1993, and even now, probably even higher, we see often 20,000 cases per year. Okay, so that wraps up our discussion on lower respiratory tract infections. If you have any questions, please contact your instructor. Thank you.